This chapter focuses on glucocorticoids. There are not too many agents listed on the beginning page of this chapter. However, the majority of the lecture will focus on prednisone, as that is the most commonly used glucocorticoid in primary practice. Glucocorticoids, or what we'll refer to as steroids simply because it's easier, are used to treat numerous disorders, disease states, exacerbations, and symptoms of other injuries or diseases. The primary actions of steroids are anti-inflammatory and immunosuppressive. As I had mentioned in the previous slide, the review of these medications will be in a very broad spectrum or sense. Some of the common disorders that are treated with steroids include seasonal or perennial allergic rhinitis, drug hypersensitivity reactions. More commonly, we'll think of steroids being used as burst or chronic therapy in the treatment of COPD, chronic obstructive pulmonary disease. They're used for the treatment of ulcerative colitis, rheumatoid arthritis. Steroids will be part of a treatment plan in multiple sclerosis. We will think of injection of steroids being used to treat inflammation in joints or any type of bursitis. And then it is also common to see short courses of steroid to treat pain or inflammation that is associated with chronic degenerative diseases like chronic back pain due to bulging discs. Finally, steroids are commonly used as part of the drug cocktail to inhibit organ transplant rejection. The glucocorticoids are split up into three groups: short-acting, which includes hydrocortisone, sold under the brand name of Cortef or hydrocortisone; medium-acting steroids, prednisone, prednisolone, triamcinolone, and methylprednisolone. Methylprednisolone is solumedrol in the injectable form and a medrol dose pack, which is commonly seen in the primary care outpatient setting. And lastly, long-acting glucocorticoids are identified as dexamethasone, which is available in oral and injectable preparations, and betamethasone. All of the drugs in these classes are remarkably similar in their mechanism of action, their affinity for various enzymes in the body and various chemicals in the body. Most of their differences really lie in their duration of action, so how long they last for, and their degree of mineralocorticoid activity, which we'll go into a little bit more detail in the following slides. Hydrocortisone is a naturally occurring glucocorticoid, and in terms of the activity of all the glucocorticoids, the agents are all compared to hydrocortisone. So something to keep in mind is that prednisone has 4 times more anti-inflammatory potency than hydrocortisone does. And if we're curious on dosing equivalents, this chart that I've created here helps you understand which dose of each glucocorticoid corresponds to another agent's dose and how they are ranked from least potent being hydrocortisone to most potent being dexamethasone. So pharmacists use these tables to convert. If somebody takes 5 milligrams daily of prednisone at home, we could convert them to 20 milligrams of hydrocortisone, and then we could go through further calculations and equations to figure out how much IV hydrocortisone they might require if IV steroid dosing is necessary in various hospital setting situations, times of stress, which would be in extreme illness, surgery both pre and post-operatively, or an exacerbation of a disease that was previously being treated with steroids will sometimes then require IV steroids. So knowing dosing equivalents is helpful because it allows you to move from one steroid agent to another, ensuring that you're giving them at least as much medication that they would need, if not more, when more drug is warranted. So we noted that the differences in the glucocorticoids was with their duration of action and their potency, but now we'll focus on their mineralocorticoid activity. Mineralocorticoid activity causes sodium and fluid retention, and this is especially important in patients that might have adrenal insufficiency. Adrenal insufficiency is a condition in which the adrenal glands do not produce adequate amounts of steroid hormones, primarily cortisol, but also have impaired production of aldosterone, and aldosterone is a mineralocorticoid. Aldosterone regulates sodium conservation, potassium secretion, and water retention. So in patients that have an adrenal insufficiency, they themselves don't have enough exogenous or natural aldosterone. So supplementing them with a glucocorticoid that has mineralocorticoid activity allows for the sodium and fluid retention that is necessary, to kind of balance life, if you will. Mineralocorticoid activity, however, is not needed in cases of severe inflammation. So that's why understanding a steroids' relative activity as a mineralocorticoid is important so that you're getting the effects you need but not adding unnecessary effects for the patient. So hydrocortisone and cortisone have both mineralocorticoid and glucocorticoid properties. Prednisone, prednisolone, and methylprednisolone, on the other hand, have predominantly glucocorticoid properties, whereas dexamethasone, which is called Decadron, triamcinolone, and betamethasone have only glucocorticoid properties. So as you start to learn about different disease states or different symptoms that are treated with steroids, you may be asked to recall what type of properties they possess. So if you can remember, hydrocortisone has both. Prednisone is mostly glucocorticoid, but dexamethasone is only glucocorticoid. That's a really good place to start. Glucocorticoids have a lot of different mechanisms for exerting their, large array of actions. One of the things that they do is they affect the metabolism of carbohydrates, proteins, and fats. So simply put, glucocorticoids will stimulate gluconeogenesis in the liver, so that's the production of glucogen, and inhibit peripheral glucose use. So you now have a larger pool, if you will, of glucose available to the body to use for energy. A diabetogenic state can occur when large doses of glucocorticoids are used. So we will see glucose tolerance decrease, insulin resistance increase or develop, and glucose may be present in the urine. When we give steroids to folks, it makes it appear as though they have diabetes, but we know that it's really just a relative glucose intolerance while they're on steroid therapy, and that when they complete that steroid therapy, most patients will go back to normal blood sugar levels. So as an example of something we see in the clinical setting a lot is we'll have patients, and they're typically elderly patients who are not classified as diabetics. They'll get a pretty aggressive burst of steroid dosing for, let's say, a respiratory disease. And some of the clinicians that I have been in practice with will be rather aggressive in treating that and will want to start those patients on insulin injections, for example, to help control their blood sugar levels while they're on the steroid. I tend to err on the more conservative side of that, knowing that these elderly folks are responding to the glucose. We expect their blood sugar levels to elevate, even quite high. I've seen them in the 200 and 300 range, but we know that short duration of elevated blood glucose levels when we have a definite cause are not excessively detrimental. So I would be on the side of letting those blood sugar levels ride out, knowing that they're going to return to normal once the patient has completed the therapy. Now, on the flip side, we will have patients who are classified as pre-diabetic, who we then begin on a course of steroids that increases their blood glucose levels through the same mechanism that it does to the non-diabetic little old ladies, and they just don't completely recover to normal blood glucose levels following the completion of their steroids. So sometimes the addition of a steroid to a pre-diabetic patient is the straw that breaks the camel's back, and their latent diabetes is then exposed and expressed from then on out. But most of the time, elevated glucose levels or glucose intolerance is just relative to the course of steroid therapy. The way that glucocorticoids affect the metabolism of proteins is really manifested in impaired wound healing or thinning of the skin. So those are things that can actually be visualized. Long-term steroid use causes thinning of the skin, and if you're using steroids to treat, let's say, pneumonia in a patient who also happens to have cellulitis, you might have decreased or impaired healing of that cellulitis, because if you'll recall, not only do the glucocorticoids have anti-inflammatory actions, they also have immune reactions or actions as well. Glucocorticoids can also affect the metabolism of fats and change the areas in which the majority of the fat deposits in a patient. So long-term use of steroid therapy can result in increased deposition of adipose tissue in the back of the neck. That's referred to as a buffalo hump. And then in the cheeks of the face, which is referred to as moon facies. So those are terms that you might hear in patients that have been on long-term steroid therapy. That is the side effect of redistribution of fats. The glucocorticoids also have direct and indirect effects on the immune response in the body. We know that they modulate the inflammatory response, and they play a role in the body's ability to respond to stressful stimuli. That's the fight or flight mechanism. So they actually potentiate the effects of the catecholamines, and the catecholamines are hormones that are made by the adrenal glands and are released in times of physical or emotional stress. And we know that those catecholamines lead to increases in heart rate, blood pressure, and blood glucose, which all helps us in our fight or flight response. So it should make a little bit of sense, or there should be some neurons firing in your brain right now that say, okay, if I'm supplementing somebody all the time with steroid, I have probably amped up their ability to make catecholamines. So I've reset their normal of how much hormone they're producing. So in a setting of stress, a patient cannot make as many catecholamines as they need to overcome that stressful situation, because your body becomes a little lazy when you're giving the patient glucocorticoids. The body doesn't have to work as hard to create those responses because the drugs are doing it for the patient. So that's just something to keep in mind when you're thinking about steroid dosing and how that plays into stressful situations for a patient. So to specifically talk about the immune response mechanism of action, it's important to understand that glucocorticoids do not decrease the levels of circulating antibodies. Rather, they interfere or inhibit antibody creation because they don't allow the macrophages to function in their normal way, and they limit the production or activation of lymphokines. So we're not taking away the antibodies that you have, we're just not letting you create new ones. And that makes sense because you don't want to eliminate all antibodies, for example, in a patient that recently had an organ transplant, because how else would they fight off infection and illness? But you don't want them to create new antibodies that are going to attack that new organ that's been transplanted. Additionally, the glucocorticoids will block several steps in the T cell activation cascade, which inhibits the cellular immune response. And that's the part therapeutically that really plays a role in blocking rejection after organ transplantation. So the anti-inflammatory mechanism of action of glucocorticoids then is to inhibit the early manifestations of inflammation, which are local edema, capillary dilation, and the migration and activation of white blood cells, and to also inhibit the later effects of inflammation, which is the proliferation of capillaries and collagen deposition. So when we combine the immune response mechanism of action with the anti-inflammatory mechanism of action, glucocorticoids become very effective in treatment of acute asthma exacerbations or allergic reactions. So oftentimes the effects of the glucocorticoids are not from one particular thing, but from the fact that they have a expansive effect on multiple systems throughout the body. Because glucocorticoids can block the usual or characteristic signs of infection and or inflammation, because in most cases that's what we want them to do, practitioners have to be especially mindful of the adverse effects of glucocorticoids. So knowing how they change various systems in the body, because sometimes that masks the very symptom that would be the precursor of something not so great going on in the body. So let's get to the treatment principles, the part that really matters for all of you. I think it's safe to say that if you can become fully immersed in and understand prednisone, you're going to be just fine in primary practice, as this is the drug of choice for most disorders that are seen in primary care. It has a medium duration of action, it has minimal mineralocorticoid effects, and it's very low cost for just about everybody, even cash paying patients. Some of the common dosing schemes that we see, 2.5 to 5 milligrams daily is typically sufficient for the treatment of chronic, or for chronic treatment of really anything. When you start to get above doses higher than 5 milligrams, I'm not going to tell you that it's uncommon, but most disease states can be chronically managed with 2.5 to 5 milligrams. Steroid burst dosing is done in this fashion. This is a burst dosing scheme that we use, it feels like, just about every day in the hospital. 40 milligrams daily times 3 days, followed by 30 milligrams daily times 3 days, 20 milligrams daily times 3 days, 10 milligrams daily times 3 days, and then back to the patient's either usual maintenance dose or just completely stopping the steroid altogether if the patient had not been on it previously. And in the following slides, we're going to talk about when you do have to taper a dose and when you can just give someone a short course and then call that short course the end of it. It's important to understand that not every dose of steroid needs to be slowly tapered. Oftentimes, clinicians will do it to provide extra symptom relief for patients, but in terms of safety, there's fewer definitions of hard and fast rules for tapering, but you'll get an idea of kind of when it's a good idea to taper in the following slides. So short-term use of glucocorticoids is classified as anything 2 weeks or less, and in those patients you actually don't need to taper the dose. Even if you're giving a high burst steroid of, let's say, 40 or 50 milligrams daily and just casually backing off, you don't have to do a full taper like we had reviewed in the previous slide. And when you're doing short-term use of glucocorticoids, there's no routine monitoring or really any follow-up monitoring that is required. So even high-dose steroid use for less than 2 weeks, you do not have to gradually decrease the dose in order to discontinue it. It is standard, however, that 2 to 3 week courses are usually tapered to really prevent symptom recurrence. So if we taper, we give that patient exposure to the steroid for a longer period of time, and even when the steroid's done, the patient will have a couple more days of sort of the steroid effect in their body. And sometimes we do that just to make the patient feel better. It's especially important in maybe COPD patients who are having an exacerbation. That feeling of shortness of breath can be very disconcerting for a lot of patients. So if we taper the steroid slowly, they sort of overcome that symptom better than if we just give them the burst, which cures the inflammation, quote unquote, and stops that exacerbation, but doesn't really provide sort of that peace of mind that a patient may need. Long-term use then requires a gradual reduction in dose. Chronic doses should be used at the lowest dose, and you'll know that you've hit the lowest dose when the symptoms come back. So if you're toggling between 5 and 2.5, and at 2.5 the patient is just a little bit too symptomatic, you know that 5 is your lowest manageable dose for that patient. The monitoring then that is required in patients that are on long-term glucocorticoids is blood work, monitoring of weight, blood pressure, bone density, and vitamin D, because vitamin D usage and kind of store levels in the body can be altered by steroid use. You can actually have vitamin D deficiency. And vitamin D deficiency, along with poor calcium intake, will obviously decrease a patient's bone density. Another thing that has to be considered with long-term use of glucocorticoids is the suppression of the HPA axis, which we'll go into in the next slide, but figure 51.1 in the book has a nice pictorial of what that is. So in the hypothalamic pituitary axis, or the HPA, you have the hypothalamus, the anterior pituitary gland, and the adrenal cortex, which all release various hormones that, through negative feedback, tell those parts of this axis when they need to excrete more or back off on what they're excreting. So the primary care uses of glucocorticoids are mostly short-term, but steroid administration really in any level can suppress the HPA, which leaves the body then compromised during periods of physiological stress because you have complete or partial dependence on the steroids that you're taking exogenously from without the body rather than the endogenous steroids that you have within your body. So you sort of cause an atrophy in this system, and it no longer can create ample supply of these hormones to create the natural negative feedback that is necessary and the natural amping up that is necessary when stressful situations present themselves. Recovery of HPA suppression can take up to 12 months if patients have been on high enough doses of glucocorticoids for long enough. So the use of a short-acting agent or an alternate day dose regimen can be considered for long-term therapy. The administration too of a double dose every other morning has been found to cause less suppression of the HPA axis because the every other morning dosing makes your body work on the mornings it's not receiving the steroid, so that it can generate the hormones it's going to need to function for the rest of the day. I got to tell you, I don't see that double dose every other morning used very often in practice, but I'm going to start to keep it in my back pocket now as something for patients that are on long-term steroid therapy, as it may be an alternative to cut back on adverse effects and to kind of preserve the endogenous function that we need in order to keep things going for ourselves. If you look in the book, there's quite a few adverse effects of glucocorticoids that are listed. I'm going to focus on some of the more notable ones. Indirectly, glucocorticoids can affect the central nervous system. So we will sometimes see changes in mood for patients, and mostly it's an upregulation of mood or a euphoric state. However, there have been cases where anxiety or depression is reported with steroids. So encouraging an open line of communication with your patients is going to be necessary to make sure that they don't tip the balance in that at all. It's not uncommon to see insomnia in patients that are taking steroids. So taking the dose earlier in the day has some other benefits we're going to get to in the next slide, but it helps decrease insomnia if you take the steroids earlier in the day. Cardiovascularly, we can see glucocorticoids contribute to hypertension. Metabolically, as we've kind of talked about in their mechanism of action, we can see increased insulin need in diabetic patients, and that's because of the overall increased state of glucose availability in the body, and an increase in hunger because we are ramping up the metabolic actions in the body. And lastly, one of the kind of forgotten side effects, but I think it's rather important, is that glucocorticoids can cause ulcers. So if you're going to have a patient on burst steroid dosing that's kind of an extended taper, or even patients that are on long-term low dose, 5 milligrams a day of prednisone, you may want to consider the addition of something like an H2 blocker or a PPI so that you don't have caustic effects on the gut from the glucocorticoid agent. To wrap up the glucocorticoid lecture, then, we'll look at a few patient education pointers. If possible, patients should be educated to take the entire daily dose before 9 in the morning. The reason that we want patients to take the dose early in the morning is because it helps limit interference with natural hormone production. In essence, taking all the drug before 9 in the morning, it allows, or it's what your body would expect to happen, because the peak of natural activity occurs upon wakening. So we're mimicking what the body's expecting to happen if we're taking all of the steroid first thing in the morning. Take with meals to avoid GI irritation. So in the last slide, we talked about a potential side effect of ulceration. So prescribing a GI protective agent may be necessary as well. Anticipate certain common side effects that are troubling, but definitely not serious: mood changes, insomnia, and increased appetite. So those are the ones you're really going to want to commit to memory. Learn the signs and symptoms of adrenal insufficiency, which is more common if you're decreasing the dose and maybe you've decreased it a little bit too far, or shortly thereafter the completion of a steroid course. Patients will want to watch for fatigue, weakness, nausea, diarrhea, weight loss, dizziness, or shortness of breath, which is dyspnea. Lastly, patients are going to want to be counseled to avoid immunization with live vaccines, and that's because you are unable to mount an appropriate immune response due to the alterations in antibody formation. If you'll remember, steroids don't affect the antibodies you currently have circulating, but it limits the production and inhibits the production of new antibodies. So those are some big points to remember when thinking about treating patients with steroids and educating patients about their steroid use.